Now, once you've determined which vessels you're looking at, we would then carry the examination out through the proximal, mid, and distal portions of the internal carotid artery. And in our facility, we have strict definitions about determining the portions of the internal carotid artery. The proximal ICA, of course, is typically that dilated area just beyond the carotid bifurcation, usually a 1 to 2 centimeter segment distal to that level, and this is the area where disease is most likely to develop. Keep in mind, this is where most of the action will happen, here at the origin of the internal, sometimes the carotid bifurcation. All of the criteria that's out there and used for estimation of carotid stenosis has been validated for disease that involves the internal carotid artery at its origin. It's not applicable to the external carotid artery. It's not applicable to the common carotid artery or to the distal ICA. Although it is important to look at these vessels, the stenosis criteria really should be applied only to the origin of the internal carotid artery and sometimes the carotid bifurcation. The mid-internal carotid artery, of course, the examination is carried on throughout the whole portion of the extracranial carotid, but we define the mid portion of the internal carotid artery as that area about 2 cms beyond the bifurcation. Typically beyond that dilated area, the vessel walls tend to be straight and tend to be a little bit more normal diameter. In some cases, disease may extend out into this area, but in my experience, it's unusual to find a patient who has disease that involves only the mid and distal portions of the internal carotid artery, in the absence of disease in other areas of the extracranial carotid artery vasculature. And this is important because you don't want to make the mistake of diagnosing a high velocity as an atherosclerotic plaque in the absence of plaque in other places. Now, you can absolutely have pathologies out in this area, typically not referable to atherosclerosis, especially, again, when there's no disease anywhere else. But for instance, if a patient comes in after a car accident and maybe has a seatbelt injury or has some trauma to the neck where you're eliciting a focally elevated velocity in this area, it's more likely to be a traumatic injury such as a dissection or an intimal flap rather than an atherosclerotic lesion. And this does make a difference in terms of treatment for that patient. The examination is then carried out through the distal internal carotid artery, and that is that segment that's at least 3 centimeters beyond the carotid bifurcation. Again, this is an area where atherosclerotic disease is not usually seen, although you can encounter other pathologies, most commonly things like fibromuscular dysplasia. It's not uncommon to see loops such as you see here, or kinks, or coils. Occasionally you see these S-shaped tortuosities, and when you see these tortuosities, kinks, and coils, they can all result in difficult angles for evaluation and therefore artificially or artifactually elevated velocities. And typically what I would do in the evaluation of these patients when trying to elicit flow disturbance, if I suspect that there's pathology, is I'll use a 0-degree angle and just step that sample volume through the whole portion of this part of the internal carotid artery to look for flow disturbances, potentially the presence of post-stenotic turbulence. But keep in mind, again, it's unlikely that a flow disturbance in this area will be referable to an atherosclerotic lesion, and therefore your interpretation needs to state that accordingly. We would then complete the extracranial carotid examination with an evaluation of the external carotid artery, and that flow velocity signal really is obtained at or near the origin. Primarily, it's used to distinguish that vessel, the ECA, from the internal carotid artery, and we do that primarily, again, based on the shape and morphology of the waveform, which should differ from the internal carotid artery, as I've already described. The examination then is taken out to the vertebral artery, and the best way to identify this vessel is really by straightening the patient's head out just a little bit, using a very anterior approach to identify the common carotid artery, and then angling that transducer laterally, where you'll usually be able to identify an image such as this one, where we can see the vertebral artery body, the spinal process, and then the vertebral artery again. And this is a classic image for the vertebral artery. We would probably evaluate the vertebral artery somewhere in this area using the appropriate Doppler angle to assess for the direction of blood flow. keeping in mind that flow should always be moving from the heart out to the brain, in this image from your right to your left. So we would set the color scales and the color direction appropriately and look for flow either moving towards or away from the transducer. Now, if you suspect a stenosis or some atherosclerotic process to be going on in the vertebral artery, which is not common but can happen, typically that will happen at the vertebral artery origin. And the best way to define that and identify that is first by finding the vertebral artery in the mid-neck and using the color flow image to allow you to work backwards to its origin and then evaluate the vertebral artery origin for the presence of stenosis. This is a typical vertebral artery waveform. It will somewhat mimic that or be a combination really of the common and the internal carotid arteries. It should be low resistance because it feeds the brain directly through the basilar artery where both vertebrals come together. So really you should be seeing a sharp upstroke, which again you should see in all vessels within the carotid system in the absence of significant proximal disease, but lots of diastolic flow. Here in this case we see a series of various waveforms, and it won't be uncommon to see something like this here where on your top right. It's a waveform that we refer to as a systolic hesitation, where the peak, in fact, of the waveform is displayed below the baseline. And this is the type of waveform that you might see in a patient with a latent steal. These patients who present with subclavian steal syndrome, which would be an indication to look at the subclavian arteries. And really, this is a phenomenon that occurs in patients who present with proximal subclavian artery stenosis, proximal to the origin of the vertebral artery, so that what happens is as the heart pumps and it pumps out the blood, the flow will traverse up the contralateral vertebral artery, around the horn, and then move in a retrograde fashion down the ipsilateral vertebral artery to perfuse the ipsilateral upper extremity in the presence of this subclavian artery stenosis, which is no longer able to perfuse the arm. When you see these patients, they often will come in with asymmetric blood pressures or symptoms referable to the posterior circulation. The peak incidence is in patients who are between the ages of 40 and 60 years. Males outnumber females 2 or 3 to 1, and it can also be seen in patients younger than 30 years of age, in patients who have Takayasu's disease or giant cell arteritis. Now, these patients can come in and demonstrate various vertebral artery flow pattern changes, usually consistent with the degree of disease within the subclavian artery, and in fact may have a normal waveform at rest or can yield systolic hesitation. They can sometimes present with an alternating waveform or may just come in with complete reversal when the stenosis within the subclavian is very severe. Now, in patients in whom you suspect a subclavian steal syndrome who present with normal waveforms, we can do post-occlusive reactive hyperemia testing, and this is very simply done by placing a blood pressure cuff on the ipsilateral arm and inflating that cuff to a suprasystolic pressure while monitoring the flow changes within the vertebral artery. After 3 minutes or so, that cuff can be deflated. Of course, we're creating a hyperemic response here in the ipsilateral upper extremity, and if that subclavian stenosis is significant, the flow within the vertebral artery will reverse. Some patients, if they can, you can allow them to exercise while evaluating the changes in the vertebral artery. And again, if the subclavian artery stenosis is hemodynamically significant, you really should see some changes within the vertebral artery. Again, these are some of the symptoms associated with vertebral artery disease. Posterior circulation symptoms include dizziness, drop attacks, lightheadedness, visual disturbances, and these are a few of the other symptoms associated with patients with this type of disease. When they present, you really should be evaluating the subclavian artery. Now, of course, a normal subclavian artery will yield tri- or biphasic flow depending on the vasomotor tone, typically high resistance in nature. All vessels, again, should have a sharp upstroke and a systolic peak. When disease starts to set in, you'll see an increased velocity and turbulence, with increasing turbulence with greater disease severity. Often these patients in very severe forms of the disease will present with delayed systolic upstrokes and rounded peak velocities. And then the end-stage manifestation in patients with occlusion would be this very blunted, sometimes tardis parvis waveform. Now that's the evaluation of the patient with carotid artery disease in terms of the use of carotid duplex ultrasound. If you want more details about these professional performance guidelines, I would refer you to SVU's website. That's www.svunet.org, and very soon we'll have some DVDs that will also go over the technical performance of these examinations. Thank you very much. I wish you good luck and happy scanning.